So she's 9 years old. He presented with dyspnea in a low functional class. She has a history of hypertension, diabetes, obese, kind of morbid obesity with the body mass index of 37. She suffered also from hyperthyroidism, venous insufficiency, chronic AF, and also a previous hip replacement with some sequela with limitation in her motility. The AEC, she presented with atrial fibrillation with some kind of disturbances conduction in the right branch. So this is one of the reasons why we implanted pacing before I start the procedure. The blood test, nothing special about that. In the echo Doppler done in another hospital, they observed a tricuspid valve with severe aortic stenosis with a small area, the 0.6 with low gradients, 35 and 21 with a normal left ventricular ejection fraction with a systolic volume of 36, with a calcium score of 1300 as you observe there in the next slide. So in a way, she can be categorized as a severe aortic stenosis with a low flow and low gradient according to this echocardiographic and CT scan evaluation done before this procedure. As usual, we perform a coronary angiography before the procedure. This is the right coronary artery, which is dominant with no significant lesions. On the left coronary artery, the left main is normal, and also LAD and the circumflex are big branches with any kind of significant lesions. This is the CT evaluation in the core lab. This is an evaluation that we did here inside in our team. It's quite similar, 18 by 21 the perimeter. The mean is quite similar. The perimeter is 2 millimeters smaller, so in a way it's similar. The osmium height is 11 and 11. And there we found a projection for the cusp right and left cusp overlap of right obliquous 12 and caudal inclination of 8. We also observe here the smaller sinus, no significant calcification in these leaflets. So this is the sinotumoral junction, no significant calcification there. This also is small, 23 millimeters as a maximum. And this is a coronary height. Here is 11 for the right and 10 for the left, but we did other measurement which is between 11 and 12. And the sinus height is 15 millimeters. So this is the angulation of the aorta, 44 degrees, and this is the cusp overlap view. And this is the evaluation for vascular access. In a way, she is a big lady, but with small femoral arteries. We were a little bit worried about that. This is an images, but anyway, the diameters are above 5.5, which is enough, even better, because there is not any significant calcification in both iliac arteries, and bifurcation of the external or the common femoral, is below the femoral head. This is the image for the left, quite similar, no significant angulation or tortuosity in the aorta. We had decided to the perimeters, we are in the borderline between the 23 and 26, but there is one measurement above the 63, and the lady is very big. There are no significant calcification in the leaflets. This is the reason we have decided to go with 26. The issue is she has smaller sinus. That's why we stay in the instruction for use for the 26. So in summary, we have an octogenarian with severe aortic stenosis with normal flow but low gradient and morbid obesity. Although she has a low STS score for mortality or morbidity, the heart team, according to all her clinical conditions and the frailty, and they decided or suggested transcatheter aortic valve implantation, TAVI. Next. So in our plan, we have prepared the patient for a transfemoral and direct implantation because, as I showed you before, there is not significant calcification in these valves. As you can observe here, probably if you do some zoom here, we have a femoral access in the left femoral artery, which was very difficult because she is too obese. Although we use angio and echo, it was not that easy to puncture. And also we have difficulty for the femoral access. This the reason why put the transient pacemaker from here, from the right side, which is quite uncommon when we are doing a femoral approach. We cross over with a pigtail and a hydrophilic wire with a high support. And so after that, with the puncture, we put the 6 French introducer and we use 2 proglide. We were a little bit scared because the distance between the skin and the artery is really long, but anyway, the proglide did it well. We have a wire in the ascending aorta. We are going to introduce a 5 French pigtail to cross the valve. We have prepared the valve. After crossing, we will check if the valve is properly loaded. Some comment from the echo. Dr. Diego did, mostrame más arriba, did an evaluation before, and the gradient today is a little bit higher. The mean gradient, how much is the mean gradient now?
34.
Okay, 34. So we will try to cross in the simplest way with the pigtail and the G-wire. Remember that this is not a commissional fusion. It's like the Sherman Cars star symbol with a limitation of the motility of the leaflets. So if you find this the space between the leaflets, it's easy to cross like now. Right oblique. So now let's go with the pigtail to the apex. We can measure gradient here. So now we can do 0. Okay, perfect. We are not going to expect a very high gradient. It's almost according with the Doppler. We have 60 of between 50 and 60 as a peak gradient. This is the confida wire. We have reshaped it in a small loop in the distal tip of the wire that we normally use it, but in this patient with this small ventricle, very hypertrophic, I think it's important. We introduce also a second bend that we normally use in case we have some difficulty to retrieve the nose cones. If we pull the wire, in some cases we can centralize the nose cones inside the very distal part of the valve and to prevent any kind of movement. So before introducing the wire, let me reshape a little bit again. So we will introduce the wire. We have checked the valve. Patient is stable. Now, Juan, I need your help here. So we can put the valve there. The patient is a little bit unstable with a lot of stress beats. We need a little bit more. Un poquito más caudal. Okay. Y un poco más derecha. Quédate ahí, Juan. Okay, this is a final adjustment that sometimes are needed. Well, Position is quite uncomfortable, so I think we have to do it here in the near cusp overlap, which is important here, and we have observed this is a very small annulus and sinus for such a big patient, quite rare. First, before introducing the valve, don't pull the wire too much. Déjamela. Ahí, adelante. If we can show here, zoom out, we can see the handle here, and you can observe here the port is oriented at 3 o'clock. So in this position, in about 80% of the cases, as Professor Tang told to everybody, we can reach a perfect commissural alignment. So Franco is holding the wire, but don't pull it too much. Sí. Déjala venir un poco. And we are introducing the valve. So the advance is very smoothly. We will park in the middle part of the pigtail loop. Move there, Juan, guarda. Be prepared with the pacing, 120 or probably 40 because she is with some tachycardia. Test, Juan. Small test. You can. Let's do a zoom. One zoom. Perfect. And move a little bit down the patient. Mueve la cama. There. Perfect. So we can start very slowly, Franco. One is a very small path. Perfect. A little bit higher. Carmen is prepared because we are ready to deploy the valve. Path. Okay, 140. 140. Spanish. Pull the wire a little bit. It's very unstable. Path. Let's go, Franco. We cannot go that high as usually work. Dale. With heavily calcified valve because we don't have calcium for baja el marcapaso for stability of the valve. Let's test. Okay, the valve is a little bit deep, but I don't want to go too high because the lack of calcium. Let's go to the left, to la izquierda rápido because the patient is hypotensive. Test. Okay, I think the position is okay. Mostrarme más arriba. Marca paso de vuelta y vamos, dale, despacio. Sí, 140, I will push, don't pull. Okay, let's go. Slowly, very slowly. Test. Okay, we are okay. Now, fast. Okay. Perfect. Okay, now we have to recover the patient to see what's going on. The pressure is coming back. Let's retrieve first the pigtail. So in case we have some difficulty, we can push the delivery system. I am pushing the wire and very gently pull the cutter. So sometimes we can be very precise, very gentle to change position. But like yesterday, when we did a patient with 10% ejection fraction, we had to decide to deliver the valve as soon as possible because if not, you might not have patient. So I am pulling the wire. As you can observe there, I can centralize the nose cone. And now I push the wire. and I have the delivery system with me. So we will prepare the introducer. We can you imagine when the medicine virus were discovered very few decades ago, and now these fellows are training in a live session that started yesterday in China with a kickoff in New York, and now we are participating. Such a huge change in these past 20 or 30 years, and such a great, contributors like Samir and Samir with a live transmission for so many years, teaching us how to do it, how to handle the situations, and now with this extremely important project. So we will do a small test before, just to see. Remember, the valve is going to be a little bit deeper than we usually implant. Let's put 25 because she's with heavy tachycardia. But I think no, we don't have to use more heparin because we're almost done. I think the outcome is beautiful. As you can observe, almost both sinus are completely collapsed. So probably the depth of the valve is not that deep as is seen here in the aortogram. Let's put in AP view and let's check by echo. I think if I were go a little bit higher, I would have some problem with the left main. She has conduction disturbances. She has AF and also ME block of the right bundle branch. So this is a patient not for being discharged the same day for sure. We will leave the pacemaker. This is afternoon, so probably until late today or tomorrow morning, according our working hours today.
Valve is in good position. Is the
So the valve is in good position.
Maximum
Yes.
gradient is
The mean
50
gradient?
and medium 5.
Medium gradient is 5. Okay, and what about aortic regurgitation? Will you show the images?
Yes.
Okay, perfect. So you can observe there, peak gradient is 15, mean is 5, and almost no rigor. Is that okay?
Yes.
What about pericardial diffusion?
There are no aortic regurgitation, ni leaks, no leaks.
Minimal leak. Okay, so we can put
no leaks.
No leaks. No leaks at all. Okay. So the patient is still a bit under low pressure, Carmen. Do you believe it's some lack of volume or something like this? So we will increase. Is she receiving some norepinephrine or something like this? No, nothing at all. So we will give some volume. We will put, we will retrieve the pigtail. We will do a final angio. And then 0, because zeros are lack. So we will do the angio final. So the outcome is perfect, no leak. So the valve, all the sinus are completely collapsed. I will pull the pigtail and we will try to close the groin. Our idea is to retrieve the sheath and put an 6 French introducer, just in case we have bleeding. We can easily advance an additional angio seal. Dr. Carmen did protamine to prevent heparinization. And I think we have more than acceptable closing. We can compress with that balloon for probably 4 or 5 minutes. I will cut the thread so that I don't straight the suture anymore. So Franco is gonna hold for a minute and we will close the skin. So consider that she's a heavily obese patient. We will close this groin with the 8 French angiosin.